Today's module is on mild traumatic brain injury or post-concussive syndrome. The problem with this diagnosis is that it's often unrecognized by multiple providers, primary care providers, chiropractors at times, even some specialists. Interestingly, the University of Washington, a study was done and they found that over half of patients who ultimately were found to have a concussion were not diagnosed in the emergency room after a traumatic injury. The problem for patients is that there's almost sort of a gaslighting that occurs. Patients feel like they're not tracking their lives correctly, they're failing at work or within the home, they have mood problems, they're terrified that they may be having a more serious process such as an early dementia, that sort of thing. And they're just not getting the information and the correct diagnosis in place in a timely manner. This is really unfortunate, as a number of patients have actually a pretty good prognosis. A number of concussions will resolve fairly early on. But among those who do not resolve their injuries, it's really important to give them the knowledge and the tools in order to get the treatment they need. When we go into the exam room, I will be more specific about what we look for with concussion, including with history. So for mild traumatic brain injury or post-concussive syndrome, a lot of what we want to learn in terms of reaching this diagnosis is based on history. Was there an episode of acute trauma? It doesn't have to be direct blunt trauma, the head hitting something hard. Think of shaken baby syndrome. That's just a shaking of a baby, but it can cause terrible brain damage. But typically, there is some sort of blunt trauma. Maybe it's in the motor vehicle crash population, hitting the head against the head restraint in a rear-end collision, or hitting the side of the head against a car door. There does not have to be loss of consciousness. We've learned in the last decade or two that that's way too narrow a definitional need in order to make this diagnosis. A number of patients do not have loss of consciousness, although you might tease out that they don't have a continuous memory of events. So they might say, yeah, I saw the truck coming and I don't think I lost consciousness. Well, and I say, did you actually see the truck hit you? No, the next thing I knew, I felt there was a fire in my car, but it turned out to be my airbag deployment. And so patients might just have a lapse in continuous memory. And even that is not necessary, but it supports the diagnosis. Typically there's maybe it's a disorientation at the time of the impact. It doesn't have to be quite that strong, but just feeling a bit shaken. You don't quite know, oh, my car is actually still in the middle of the road. I need to pull it over. I didn't realize that at first. I couldn't find my husband's phone number. Normally it's easy for me, that sort of thing. As time goes on, there are more pronounced problems that become clear. Patients will, for example, note a generalized headache. Later, this might become more clearly a post-traumatic migraine type headache. Not a classic migraine, but what we call photophobia. They don't like light. I have a lot of light here, but they don't like light and they don't like sound. So they have photophobia and phonophobia. Maybe blurring of vision, but without the classic scotomata that one might see. They might also have problems with balance. They will have cognitive fatigue as they try to do something more taxing, for example, at a workstation. They'll get this thickness and heaviness in the head and feel like they have to lie down. They may have trouble feeling like they're not fully oriented in space. They'll have difficulty with higher level balance, but not necessarily falling, for example. They may develop ocular motor problems where they don't feel like their eyes can really track very well. And they'll have reading comprehension problems, which we don't know, is that from an ocular motor deficit or is it from a primary cognitive problem? They may develop mood changes, become irritable and withdrawn. They often develop secondary sleep problems. So these are all symptoms that are associated with a mild TBI. The good news is many patients get better, even within days or weeks. I think many people here know that who are watching this video. But if you have persistent problems, you don't want to be underdiagnosed. And so typically if I have patients who've had a head injury in the last few weeks, I'll sort of say, this is what it looks like. I think you've had a concussion, but let's see how things go. A lot of those patients get better. Some of the things we can do at the bedside, we can do various tools that have been developed for concussion or mild head injury. There's something called the SCAT-5, the Sports Concussion Assessment Tool, which is used for a number of sports at the sideline to decide if a player has sustained a concussion. There's the MOCA, which is commonly used, and then even the mini mental status exam, although it's not terribly sensitive for this type of injury. So those are decent assessment tools. I don't use them that often early on because a lot of times patients will be improving. If they're not improving in terms of their ability to track with their eyes, we do ocular motor testing. We've started to use a system in our clinic called the right eye, but you can also always make a referral to a neurooptometrist, and they might in turn do vision therapy and that sort of thing after assessment. We do some work with cognitive therapy. We have a cognitive therapist in our clinic, and if it turns out that under evaluation they do have head injury findings, we will end up giving the patient cognitive therapy. And sometimes patients develop so many psychological issues as well that they need to get mental health or behavioral health referral. This can be a very difficult injury. It's called mild because its probability of killing you is extremely remote. But it's by no means mild in terms of one's quality of life. Patients have difficulty with multitasking, short-term memory, attention, concentration, executive functioning, which is sort of initiating various tasks. I know for me, if I had a mild traumatic brain injury, it would be disabling for me. The things I take for granted in terms of my multitasking abilities, etc., my fluency of speech, would be severely affected. Speaking of fluency of speech, a lot of times patients have subtle word finding problems, what we call anomia. So for example, you say, "What's this?" And they go, "Shirt." And then you say, "Well, what's this?" "Well, it's attached to the shirt. It's a collar. I get it, it's the collar." They have just a very subtle problem with finding specific words or remembering specific names. In terms of treatment, early on there's reassurance that we give. I've talked already about cognitive evaluation, ocular motor testing, behavioral health testing. I encourage patients to actually use some caffeine during the day, maybe green tea to stay alert. But I also encourage them to take naps and to pace themselves. Sometimes they need a gradual return to work. A number of patients will use fish oil, which has been shown as a supplement to be helpful for head injury. In our clinic, we give a cocktail of fish oil, carotenoids, and vitamin E. We are also looking into hyperbaric oxygen therapy as a treatment for TBI. This is not FDA approved yet, but it's been promising for some groups, including with disabled veterans who've had blast injuries. And speaking of disability, what we do want to do is try to avoid complete disability for these patients. We do want to try to keep them doing something, even if it's on a avocational basis, getting outside, walking, trying to stay participating in their community until they can get further improvement in their function. These are some just broad things we do as we try to address TBI. And the final thing I'd say with TBI is where there's smoke, there can be fire. So if a patient has had a head injury, they often have concomitant spinal injuries, for example, in a motor vehicle crash. And you need to keep that in your differential diagnosis. The headache might not be purely post-concussive. It might actually be from injury to the upper joints of the neck, as I've discussed in other modules on cervical facet syndrome or whiplash injury. So keep that in mind. It's not always just about the concussion.